Hello again, everyone. Max Cohen. I am going to be talking about osteopathic manipulative treatment today, or osteopathic manipulative medicine, OMM or OMT, you might see it, and about some of the skills that are transferable very easily to other practitioners of manual hands-on medicine, like athletic trainers. And I'll just give a quick intro to what is a DO. DO is a doctor of osteopathic medicine. Andrew Taylor Still was a MD physician in the 1900s, frontier doc who basically was um, dissatisfied with the state of medicine at the time, practicing a lot of heroic medicine, not a lot of highly effective treatments. So he sort of went searching for other styles of medicine after some of his family members passed away from meningitis, and studied a lot of different forms of Eastern medicine and other healing techniques internationally, and he came up with osteopathy. Some of the tenets of osteopathic medicine, basically that the body is a unit made of mind, body, and spirit, and that it is a self-regulating, self-healing mechanism, that our job as practitioners is to try to assist the body in its own self-healing processes. Number three is a big one here, that structure and function are reciprocally related. So that means that structure of the human body in sort of influences the function, and likewise, function will influence the structure of the body as well. And we'll talk a little bit more about what that means. And then the last part here, basically, that rational treatment would be based on the preceding principles. So to apply these in osteopathic medicine, we look for what's called a somatic dysfunction, and then we use different techniques to try to treat that. So in this presentation, we're going to talk a little bit about how to evaluate different parts of the body for somatic dysfunction, and then we'll talk briefly about some general techniques, and then in class we can work on how to actually perform those techniques in much more detail. So the somatic dysfunction is basically that altered function that we're going to be picking up from different body systems, and that could be the skeletal system, joints, could be myofascial structures, might be vasculolymphatic or neural even. And what we're looking for generally are called TART findings. So that's tenderness, asymmetry, restriction of range of motion, and tissue texture changes. So it stands for TART. And when we do our TART exam, we can press around to look for tender areas. We can look at, how one side of the body compares to the other in alignment to look for asymmetries. We can look for restrictions in range of motion of different joints. And then the tissue texture changes, which you might feel, how the tissue feels a little bit different with your hands. If you look at the picture of this vertebra on the right here, so the top right, it's showing that when the vertebra rotates to the right, the spinous process moves to the left. And so if you're feeling somebody's spine and you feel that the vertebra is shifted to that the spinous process is moved to the left, and the right transverse process becomes more prominent when you're palpating, you might feel that right transverse process more prominently. That would suggest that there is a abnormal position of that resting rotation of the vertebra. And if you look at the bottom there, it shows you a really helpful indicator of something called a physiologic barrier and an anatomic barrier. So the neutral position is somewhere at the most appropriate neutral position for that joint. And as you rotate this particular joint, you move through a normal range of motion, and eventually you'll hit the physiologic barrier. That's as far as the patient is able to actively move that joint through a range of motion. And then the provider, the practitioner, might be able to move the joint even further than that through a range of passive, mostly ligamentous stretch that's taking up some of the static structures. And that brings us to an anatomic barrier. And that's the point where if you were to sort of continue pushing through that anatomic barrier, you would injure that joint and the tissues there. And then you can have a somatic dysfunction that is going to limit the range of motion within that those limits of the barriers. And here's just a quick picture about the tissue texture changes. So as this is somebody's back here, you might be feeling areas that are more edematous or boggy feeling with some hypertonicity, so increased muscle tension, and that might signal to you that there's some more acute changes or inflammation in that area, as opposed to chronic tissue texture changes. Some chronic old injuries might have a little bit less of that hypertonicity. They might even have decreased muscle tone, and it'll often feel more of a cool or a dry sensation. So when we do our screening exam, there's a number of ways to do this. This is from the New York Institute of Technology, College of Osteopathic Medicine, where they propose sort of this 10-step screening process. And you all come up with the screening tests that you like the best, but we'll just kind of go through a few here and then talk about how to segmentally assess specific parts of the body. So, a static posture and gait exam is important when you're looking for dysfunction in the body, and looking from the front, back, and side to look for the symmetry between each side. And if you put a plumb line through the external acoustic meatus on that side view there to make sure that it's sort of going through the greater trochanter and then just in front of the lateral malleolus. And you can use different landmarks to assess for symmetry, but that's one of the important components of the exam. And then gait, and you want to feel pretty comfortable with what does a normal stance phase and a normal swing phase look like. And in this case, the right leg is the blue leg here is the one that we're referring to. With a loading, mid stance, and terminal stance phase before the pre swing, toe off, mid swing, and terminal swing before they heel strike again in what's considered double support, moving between single support and double support. And looking for abnormalities, a limp or an antalgic gait can give you clues about what might be dysfunctional in the kinetic chain. Then you might move to the trunk to look for side bending and the standing flexion test. So the SLI muscles, they're called, spinalis, iliocostalis, and longissimus, that form the erector spinae, the QL, and the internal obliques, are going to be helping you to side bend and some of the external obliques as well, a little bit of the lats, and assessing for symmetry there. And then this is called the standing flexion test, feeling on the PSIS bilaterally, asking the patient to bend forward, and then looking for which of the PSIS actually moves forward furthest or first. And that would signal that there's dysfunction on that side, that's the side of the restriction. And we'll go into this a lot more in detail, but sort of 10,000 foot view here. And then you could do a seated flexion test, and a similar idea here, feeling that PSIS as the patient sort of forward bends, and you're feeling for motion at the PSIS there, and then better able to isolate sacroiliac dysfunction. And then the stork test here, stepping up on one foot, and then the other looking for changes in the PSIS height. Then moving to the upper extremity, including some seated dynamic trunk motion. These are great pictures here of the upper extremity motions that I'm sure you're all very familiar with, but looking through flexion, extension, abduction, adduction, lateral medial rotation, and horizontal flexion and extension. And looking for deficits, pain, and asymmetry there. And then having the patient rotating and side bending from a seated position to sort of lock out the pelvis and make sure that the motion that's happening is in the spine and not just in the hips. Then looking at the head and the neck range of motion into flexion, extension, lateral flexion, and side bending, lateral rotation. And then moving to the thorax and the lower extremities. In the thorax, looking at the ribs, which I will discuss a bit more shortly, but suffice to say for now that there's different physiologic movement patterns that different ribs will make in the rib cage, depending on their position in the rib cage. And so you're assessing side to side to look for deficits in, for example, inhalation or exhalation from side to side. And then using tests like the ASIS compression test, which you can see at the bottom there, and assessing for leg length discrepancies. So putting your thumbs on the medial malleoli or just below the medial malleoli bilaterally, and sort of straightening the legs out, looking for any difference in leg length discrepancy. And here's a great picture of a sacrum on the bottom left here, showing some of the articular surfaces and where you might have dysfunction in the sacroiliac joint or the lumbosacral joint. So then we can move into some segmental diagnosis. This is kind of zooming in on specific body parts. And we'll start with the vertebrae. As we were saying, the vertebrae may be rotated, but they also can bend towards the side, and then they can be in a neutral, flexed, or extended position. So in the side bent picture there, the vertebrae sort of um, uh, bends in the transverse plane towards the right or the left, and in rotation there, in the sort of a um, coronal axis or sagittal, having rotation left and right. And when that happens, we need to use something called Fryette's principles, which applies to the thoracic and lumbar regions. And Fryette's principles tell us that if there is a group curve, so multiple vertebrae that are dysfunctional together, they will be in a neutral position and they will side bend and rotate to opposite sides. Meaning, for example, if you had T2 through 5 that were in a group curve type 1 dysfunction, then they would side bend, for example, to the right and rotate to the left. And that is just a principle that is helpful because it's often much easier to feel for the rotation based on the transverse processes as opposed to the side bending. So if you can feel a prominent right sided um, transverse process, then that means that the vertebrae is rotating to the right, making that right transverse process more prominent, moving posteriorly. And because we can feel that in a group curve there, then that would mean that it's going to be side bent to the left and will be in a neutral type of dysfunction. And that's in comparison to a type 2 dysfunction, which is typically a single vertebrae. And it typically is going to be flexed or extended, not a neutral position. And these are going to be side bending and rotating to the same side. So if a single vertebrae is dysfunctional, you might feel again that that right transverse process is more prominent, so it's going to be rotated to the right. And then you know that it's also side bent to the right because based on Fryette's principles, a single vertebra with a right-sided rotation is going to have a right-sided side bending. And then you just need to assess for that flexion or extension component, which means having the patient flex forward and extend backwards while your fingers are on the transverse processes, and looking to see where the transverse process moves into a more neutral position. When it sort of resolves, then we say, oh, it resolved into flexion, so it must be a flexed dysfunction because the dysfunction likes to be in a flexed position. And we're going to have a lot more opportunity to practice this, but just so that you sort of have the basics here. And then for the cervical spine, things are a little bit different. Fryette's principles don't really apply to the cervical spine. So you can essentially think of C3 through C3, sorry, C3 to C7 as similar to a type 2 dysfunction, that they're always going to be flexed or extended, and they're always going to be side bent and rotated towards the same side. For C1 and C2, the atlantoaxial joint will typically primarily move in a rotation and have dysfunction solely in rotation. And then the atlanto-occipital joint will side slip and will sort of move side to side and will actually have a bit of a side bending and rotation component to it. But we won't get too much into that joint in class. So that'll bring us to some of the rib assessment. And here's some good anatomy pictures where you can see how the ribs are articulating with the sternum anteriorly and the vertebrae posteriorly. And you can see that the costal tubercle is lining up with the transverse process, whereas the neck and the head of the rib are articulating with a more proximal part on the transverse process as well as the vertebral body itself. And so this is helpful for when we're palpating the posterior ribs, feeling for the rib heads. We know that that's going to be sort of right over that, right in that spinous process area as it comes around to the costal angle. It's called the posterior bowing portion of the rib. And so when we're assessing these ribs, ribs 2 through 4 or 5, depending on the book, um, have more of a pump handle sort of motion. So that means that with a deep inspiration, these ribs are going to move in more of an anterior posterior sort of direction, where the sternum will lift up and away from the spinal column and create more of that anterior posterior dimension, and then move back down in that pump handle direction. And then rib 6 through 10 will move sort of superior and inferior on the lateral portions there, much like a bucket handle might move up and down on the side of that bucket, and increasing sort of that medial to lateral diameter of the chest to allow more expansion, let the diaphragm descend and take a deep breath, and that'll be ribs about 5 or 6 through 10. And then the bottom two ribs, 11 and 12, will move in sort of a caliper sort of motion where they'll come posterior and lateral, and in that posterior lateral motion bilaterally, they will also sort of increase that medial to lateral diameter on the chest, and down into the abdomen. And to assess that, you can use your hands on the just above the clavicles to assess the first rib in the top picture on the left, and then to assess the bucket handle ribs, feeling the bilateral upper chest for the chest rise to look for symmetry. Then the next picture over, using the thumbs more medially and the rest of the hand more laterally to feel those lower 7 through 10 ribs for that medial to lateral expansion. And then on the bottom right, looking at getting very posterior to feel ribs 11 and 12 in their caliper motions. And that'll bring us to the sacrum. And the sacrum, we talked a little bit about using a seated flexion test. So this is that idea of having the patient sit, feeling that PSIS, and just looking for that motion as they move into trunk flexion to see which PSIS is moving furthest or first. And some of the other important landmarks here are the sacral sulci. So that means going just medial to the PSIS bilaterally to feel the upper lateral portions of the posterior sacrum. And when you feel that sacral sulci, you might be able to feel that one feels deeper than the other, that you need to put more pressure to touch bone on one side compared to the other. And similarly, the ILAs, which is the inferolateral angles on the bottom portion of the sacrum, I'll go back just a slide here so you can see just above the coccyx on the lateral portions there. That's the inferolateral angle. That's what you're feeling for. And you might, again, feel that one is more superficial or deep compared to the other side. And this will help you identify if there's any torsion, any rotational component of the sacrum on its axis with the pelvis. And then the last test we have here is called the spring test, and that's when you actually press on the superior portion of the sacrum and try to press it forward. And if it doesn't press forward, and they have a lot of restriction, maybe pain with that, it suggests that the sacrum has a posterior rotation to it, and that it's a more pathologic discrepancy, as opposed to if there is good spring and the sacrum does spring forward and backward with a good range of motion, then you might say, if there's dysfunction there, that it is non-pathologic, that it's a more physiologic level of dysfunction. This is a scary list of all of the different diagnoses that you might make for a particular sacrum. So unlikely that we are going to try to get you to a point of expertise or proficiency with this, but to just sort of understand some of the general components and how you might treat them is kind of our goal. And when you come to a conclusion about a torsion as angular rotation on the sacrum, This is, again, how we're going to sort of diagnose it. So, doing your seated flexion to decide which side has the dysfunction or which sort of axis of rotation there might be, finding which sacral sulcus is deeper, which inferolateral angle is more prominent, using your spring test. And there's actually another test called the Sphinx test that we don't need to worry about for today. And that'll bring us to the innominates. The innominates are the bones of the pelvis, and each innominate is formed from an ilium, a pubis, and an ischium that kind of grow together to form a full innominate bone that then articulates with the sacrum posteriorly and the pubic symphysis anteriorly. And to assess the innominates, this is where we use that standing flexion test to assess for which side of dysfunction there might be at the level of the pelvis. And then feeling for the ASIS, the PSIS, and the pubic tubercle to again see which side is higher or lower, right, compared to left, or is there, are they rotated in closer to the umbilicus or out and away from the umbilicus, looking at leg length discrepancy. And all of these measurements will sort of help clue us into whether we think one of the innominants is rotated anterior posterior, if it's sort of rotated inward, which we call an inflare, or rotated outward, which we call an outflare, and then shears or slips when the left or the right side is slipped up or down compared to the other side. And then after we make these diagnoses, we think about treating them. And some of the main treatment techniques that we're going to talk about are listed here. And these are going to be some of the ones that are a bit maybe easier to pick up, but they do certainly take some time to get good at. But for now, we'll just say these five are the ones to kind of focus on. HVLA, you might have heard before, a high velocity, low amplitude manipulation. And this is a direct and passive technique where a patient is going to tend to have the cavitation of a joint having an articulation. And you might say, okay, what does direct mean? What does passive mean? Direct techniques are techniques where the joint is brought towards the barrier and you engage the barrier, as opposed to indirect techniques, which is when you bring the joint away from the barrier, or what we say is engaging the freedom, or where it sort of likes to be. And then you can have active and passive techniques. Active techniques are going to be when the patient is using some sort of assistance. They're maybe firing their muscles or breathing in a certain way. And passive techniques are going to be when the patient is totally relaxed and they're not assisting you. And so HVLA is a form of a direct and passive. Muscle energy is a form of a direct active technique. Counter strain is going to be an indirect passive technique. Myofascial release can sort of be both, and facilitated positional release is going to be an indirect passive, very similar to counter strain with a slight change. And we'll just go into a little bit more detail. Again, with the HVLA, bringing a restricted joint into the restriction and into the barrier, and very slowly bringing it to that barrier to do what we call a lockout, getting to that point where you sort of have taken up all the slack in the surrounding tissues, and then delivering a quick high velocity thrust at that end range, very small, what we call low amplitude, but very quick high velocity to bring the joint just past its restrictive barrier and restore a normal range of motion. Muscle energy is going to be that direct and active technique where the patient is going to flex their muscle in a very precisely controlled position in a specific direction against a distinctly executed counterforce. So that might look like somebody doing a bicep curl, if you imagine. If you were trying to stretch their tricep muscles, then you might have them bring their elbow into flexion, and you might be resisting that motion into flexion and then relaxing to allow for what we call a post-isometric relaxation phase, and then continuing that range of motion for until you bring up more slack, and then again use their active contraction to induce that relaxation phase, and then when they relax again bring the joint into a further degree of stretch. And then in counter strain, you use an indirect and passive technique where the tissue that's being treated is positioned at a point of ease or balance, and you bring it away from the restrictive barrier. So if you envision, again, that bicep that is tight and spasm having pain, you might flex the elbow as well as supinate the forearm, and then you might also flex the shoulder up to maximally shorten the biceps muscle. That's, think of what are all the actions that a muscle does, and then try to passively do all those motions to take up as much of the ease and freedom in that muscle as possible. And then you're holding that for 90 seconds. That's the magic number that they've come up with in the for the folks who created counter strain. With myofascial release, a bit more wide ranging, so it can sort of have both indirect and direct, both passive and active, and it can combine a lot of different types of techniques to sort of stretch and release different muscles and fascial layers to reduce restrictions, and there's a lot of techniques that sort of fall into this wheelhouse. And then facilitated positional release, I want to talk about briefly because it often will be very similar to a counter strain technique where you're bringing that body part into a neutral position and then using some sort of activating force at the level of the bicep, for example, when you make that elbow flexion, forearm supinated, and um, shoulder flexed position, you get into a neutral position and then put either a traction or a compression at the shoulder, and that activating force sort of enhances the relaxation of that muscle. So this typically only takes about 3 or 4 seconds to get a good release of that muscle due to the addition of that activating force. And so a lot of people like FPR because of that efficiency in getting some results with the technique. And that will be it for the introduction today. We'll be working on hopefully a lot of practical techniques and reviewing some of these in class. If you could also review some of the videos that were sent out to get some more detail on the introduction to each of these techniques and see a bit more about how to hands-on evaluate them and treat them, that would be great and help us kick off more efficiently come class time. Please feel free to send me any emails with questions, and good luck.